a fantastic talk, and thank you to everybody for joining us this evening. I'm going to pick up from, I guess, the next stage, if you like, on the kind of hip pathway. I'm going to focus more on what happens to the degenerative hip and the very, very common scenario of patients that need a hip replacement. I'm a hip, knee and pelvic trauma surgeon. I work at the Royal London Hospital as my NHS base. I'm also work privately with Cal, both at the London Clinic and London Bridge. We're both part of London International Patient Services, which is the group that I co-founded approximately 4 years ago. I'll just tell you a little bit about that for those that are not familiar with it. So London International Patient Services, or LIPS, is a group of teaching hospital consultants that work collectively together in private practice with a kind of ethos and idea that we're trying to match the patient with the best possible specialist, and working together both in the NHS setting and in the private setting. We feel is a very powerful means by which we can be sure that we're delivering the very best of patient care. Our group's expanded really quite dramatically over the past few years. We've been around for approximately 4 years, and we're largely initially a musculoskeletal group, but you can see that we've expanded significantly to include a number of other specialties, and those expansion plans will continue. And within the London Clinic, we're I think probably the fastest growing group. In fact, that's true in general terms. Working together, it provides opportunities such as these, and now it's of course we're adapting to the times, and this is all done over Zoom, which is okay, but having these things in person and coming together as a group and including them in educational events, I think is going to be something that we're looking forward to returning to as the COVID restrictions are lifted. And so hopefully we'll be able to host some of these events in person at the London Clinic when the appropriate moment arrives. Every few months when I'm doing one of these talks, I pick up our latest numbers, and so our numbers and Trustpilot are kind of rapidly taking off too. So we're enjoying very favourable reviews. So it would seem that we're certainly doing quite a lot well. So that's just a quick brief about London International Patient Services. So feel free to follow us through social media and check out our website, and we look forward to hearing more from you on that. So onto the topic of for me today, and that's a really, really common issue. So hip arthritis, and this is what it looks like. So the left hip is the problematic one. The left hip, you can see the joint space is gone. This is advanced arthritis. This other hip, the right side, is better preserved. You can see there's cysts forming. There is some osteophyte formation, and this is likely to be a painful and stiff hip. What do these patients complain of? They're usually the older patient, but really we're seeing, I guess, aligned with what with Cal's practice, strangely enough, getting younger and younger patients coming forward for this. The common theme is that they tend to have pain. The locality of the pain isn't always so precise, and so groin and buttock is classic, and most of them complain of that to some extent, but that pain can radiate down the thigh, it can radiate to the knee, and there are cases where they actually only complain of discomfort in the distal thigh and knee, and not at all around the buttock and groin. So it's something just to be to bear in mind. It tends to get worse with activity. It can often disturb their sleep. And one of the kind of classic signs of patients as they're losing their range is they're having difficulty to get to their feet. So quite a pertinent question is to ask them how they're managing to put on their socks or cut their toenails. Hip replacements have been around for a long, long time. I think it's always interesting to just see where we've come from and where we're going with this. So a quick snapshot. So more than a decade ago, there was 250,000 total hip replacements done in the US. So huge numbers. We know it to be a very, very successful operation. It's described across all interventions across all specialties is described as the operation of the 20th century. So these are really, really high accolades. It's been around for really a long time. This is one of the very earliest examples, and it's interesting on a number of levels, but it's interesting particularly because it's local to us. This implant was just around the corner from the London clinic in 1938, and it was a metal on metal implant. So 15 years ago or so, or 10 to 15 years ago, metal and metal implants were what we thought was the great innovation in hip replacement. And yet the very, very first example of a hip replacement is a metal and metal hip replacement. This is another example, and this one I did a fellowship. I spent a year working with one of the famous orthopedic professors in France called Professor Judet, who's the son of Robert Judet. So his father and his uncle invented this form of hip replacement, and this was an X-ray after it had been in for an incredible 48 years. It wasn't functioning too well, but it was in for 48 years. This is the guy who is attributed with, if you like, inventing hip replacement as we know it. This is Sir John Charnley. So he worked up in Wrightington in Manchester, and is probably the most famous orthopedic surgeon in the world. So he invented what we know now to be the hip replacement. This was his first attempt at it, though. This was his hip resurfacing. So he actually did hip resurfacing before he did hip replacement, but he did it with with some materials that were very, very smooth. In fact, it was Teflon. His first hip replacement was made of Teflon, and it was great, impressive results, which he reports for the first 3 months. The problem was they quickly melted away, so they didn't last too long. And what he thought was that it's because of the blood supply. He thought he'd disrupted the blood supply to the hip, and that's why these were all failing. It was actually the material failure was the big issue. But his interpretation of it was why we went to the hip replacement. And this is one of the earliest hip replacements, using bone cement, a metal implant on the femoral side, and a plastic implant on the acetabular side. And this is what went global. This is what caught on and became really put hip replacements on the map. But it's really, we've come an awful long way from then. Can you imagine when you first had a hip replacement, you used to be in hospital for 6 weeks. So times have changed. Times have changed a lot. Indications for hip replacements are pretty simple, really. This slide used to only contain pain, but actually functional loss, I think, is really an important element as well. And pain, although it is nearly always the predominant feature, it's actually the functional loss which patients can describe as being more impactful to their life. The fact that they've lost such great motion. When the hip seizes up, it puts a lot of stress and strain through your lower back and through your knee, and there's a sequelae of one joint not working correctly. And so a very stiff hip is sometimes not the most painful hip. So that's why I wanted to include functional loss in this slide. It's a really massive topic, hip replacements, and I'm not going to go through all of it because it's just simply impossible. And I wanted the focus to be on where hip replacements are going. A lot of the patients that come to me have seen many surgeons before. A lot of them are well educated, and they've come with their own opinions on what type of hip replacement they want. There's lots of choices to be made, and actually when I see a patient that comes for a hip replacement, my first consultation, we're struggling to get through all the topics and aspects of it that they may want to cover, because it's pretty vast. But these are the common choices that one has to decide on. Is your hip going to be uncemented or cemented? What type of bearing surface? What are the moving parts going to be made of? Are they metal? Are they ceramic? Are they plastic? And the sizes of the head, there's different theories on whether it's better to have a small femoral head or a bigger femoral head. And that's to do with wear and what hip might feel most natural. But I'd kind of argue that these are not actually the most important focus of how you should, how I'm treating a patient who comes looking for a hip replacement. Because actually, in each of those options, there is a place, and it's to do with multiple factors, a lot to do with age and bone quality. But the predominant feature for me when I'm seeing a patient and we're wanting to go ahead with a hip replacement is I'm aspiring to deliver them the best possible functional result. And the overriding ethos in achieving that is to try to restore their anatomy as accurately as possible. And this, for me, is where the huge game changes come in hip replacements in the last decade or so. When we're talking about minimally invasive, it's a very poorly defined description of surgery. Truly, when we're talking about it around the hip joint, actually, its definition is an incision of less than 10 centimeters. It's not really the important factor. The size of the skin incision is much less important than what happens within the wound, how much muscle damage has happened in achieving placing your components. And so minimally invasive for me is all about preserving and maintaining as many of the muscles around the hip as possible. And so there's basically two approaches that deliver that in my hands. And that's the anterior approach, where you come from the front of the hip, or the posterior approach, where you're going into a window behind the hip joint. And the important feature of each of these is that you're preserving the hip abductors. This lady, I like to use her because she's calling herself a chubby person, and she looks very different to the patients in Cal's presentation. But this is her having had her hip replacement, and she's the same day as her surgery. I know that because her surgical drain is still attached, and she's got a physio that's trying to keep up with her. So even in a patient who's not somebody you're thinking is going to be an obvious winner for surgery, an early mobilizer, doing a precise operation and maintaining their muscles just where they're meant to be allows that sense of normality and allows them to get up with confidence after surgery. The muscles we're wanting to preserve, this is the group that we're most obsessed with. It's the hip abductors. They're the stabilizers of the pelvis. They're the ones that are most important in maintaining a normal gait function. But actually, we're wanting to preserve more than that. And when I'm doing a posterior approach, I'm coming in at the back of the hip here. And there are now an evolution of the posterior approach where I'm actually able to even maintain, there's one muscle that's missing here, which is the piriformis. I'm able to maintain the piriformis and obturator internus and just go through an interval here and do a hip replacement. I did one last week in a lady, and her mode of transport home on day 3 from surgery from the London clinic was she walked home. It's pretty phenomenal. So hip abductors, this is what happens when they're not working. The pelvis sags. You're not able to maintain the stability of the pelvis, and you get an altered gait function. It's very common in patients with osteoarthritis to have this Trendelenburg gait, a gait which is deficient in the active hip abductor. That's not because the hip abductors are not strong and cannot function. It's because when they're fired, you load the hip joint, and that causes pain. And so the patient, on a kind of subconscious level, switches the hip abductors off. And so very commonly, they're walking with this Trendelenburg gait. After hip surgery, I'm wanting to fire that muscle group and get them going again. And I'm really wanting to make sure I've not damaged them, which incredibly, nearly half of all hip surgery in the country is done through an approach which goes through the hip abductors. So it's not that all surgeons are practicing this way. In restoring anatomy, I've talked already about trying to maintain the soft tissue envelope. The next element that we need to try to restore is the bone anatomy. The hip abductors, I'll go back a slide. In fact, I'll go back 2 slides. Oh, no, sorry, I won't bother. The hip abductors they connect into your greater trochanter coming from your pelvis. And so if I'm altering the anatomy, either their offset or their length, then I'm altering the length of the muscle group. If I make it too short, then the muscles are always going to struggle to generate enough power. A muscle generates power by contracting. If it's already starting life short, it's going to struggle to get back to full strength. And also, if I make it longer, it just doesn't feel natural. So we have a number of studies that show that if we do not achieve a restoration of anatomy through our hip implant, it ends up in a much less successful outcome. So we know that the offset restoration helps the muscle function, as does the length. We know that if it's lengthened too much, it feels uncomfortable, but more than that, it can wear out the component faster. So hips last less long if you alter their anatomy, which makes sense because you're not optimizing their mechanics. And so we want to get their anatomy absolutely perfect. It sounds pretty simple. The problem comes in how do we achieve it? In defining the normal anatomy, the issue is that most people that are having a hip replacement, and by most people I mean 99% of patients in the country, when they're having a hip replacement, their only form of planning will have been in an X-ray. Now, when you take an X-ray, you take two views, but the one that you do the planning from is on the lateral view. And the lateral view, to define the angles that are drawn on this diagram, depends on the position of the hip. This angle changes according to the rotation of the hip. When you've got arthritis, very commonly, the foot starts to turn out. You get external rotation of the hip. So it's already giving you a kind of false picture, and it cannot always be correctable because of the degenerative changes. So the only way to define what's actually normal for the patient is to do a CT scan. That's a normal planning process. It's a blurred image to kind of heighten the message because it gives you very minimal information. It's very inaccurate. So thankfully, there's the system that we've got available. The system I use for all of my private hip replacements and some of my NHS patients when it permits. Usually the younger patients, because their anatomy tends to be very different, and therefore a standard hip replacement may not really fit them. I use CT planning to plan every single one of my private hip replacements, and this defines very clearly the anatomy. It defines the anatomy for the whole leg. It gives me rotational profiles. It defines any deformities I have to correct. It's interesting, once you start to look at anatomy out with the hip joint, you not uncommonly find, so for example, in this example, the femora on the right is 5 millimeters longer than the femur on the left, not coming from the hip joint, but from the shaft of the femur. What I want to do in a hip replacement, you normally assume that leg length is because of the hip arthritis. With this information, I know how much I want to restore their length because I want it to go back to what is normal to that patient. And in planning, you can determine what that means. And we've got much more accurate ways of determining what actually is that patient's leg length. We can plan the orientation of the components and ensure that the components are fitting the bone correctly and choose the component accordingly. And if one of my kind of standard, if you like, hip replacement shapes doesn't fit, then I'm able to arrange for a customized implant to ensure that the implant fits that patient just perfectly. It gives me loads more information it tells me about the bone quality. It guide me, is this patient, actually this bone quality not good enough for me to try to use an uncemented hip replacement, which is my default in any patient certainly under the age of 70, which is the kind of the general guidelines. But in looking in more detail about their quality of their bone, I can actually not work on an age, but I can work on their bone quality. And so if their bone quality permits it, I can do this type of hip replacement in somebody who's 80 years old if their bone quality is suitable. And correspondingly, in a 60-year-old who is quite osteoporotic and therefore may well have a high risk of a fracture if I use an uncemented component, I may choose a cemented implant. This is a surgeon's view. This is what I can see when I'm inside doing a hip replacement with the orientation of this stem, and it's referencing it. It shows me what the anti-version of my femoral component is going to be. And this view I particularly like. This is a 3D reconstruction that shows me this is what I can see when I'm inside the acetabulum, inside the hip. And I can orientate this component to try to match this. So I'm much, much better informed in the placement of my hip replacement. And basically, this high quality planning I've seen results in a much, much happier patient and a highly functioning patient. This is one of the very first that I did. I've been using this system for, I think, about 9 years. And this lady was one of my first patients. So we CT planned it. That's her hip replacement. She's about 9 years afterwards. But this is her walking in clinic at 13 days post-surgery.
Okay, walk as fast as you can. Brilliant.
It's another lady. In fact, Carl will recognize this lady. This lady I did about, I don't know, 3 years ago maybe. She had bilateral hips that were terrible. She had an osteotomy that was done in Germany about 2 or 3 years previously, and left her without resolving her issue. She still had advanced arthritis, suboptimal anatomy, and issues around her sciatic nerve from where they'd made one of their cuts. So she was very anxious. She had a very tough time around her surgery, but she's highly functional. She's very, very motivated and enjoys running and rowing. So I did one hip replacement and then a second hip replacement, I think with a three month gap.
See you walk then. So this is us 18 hours after primary total hip replacement on the right side. We see you go back, Karina?
Right backwards.
No, yeah, turn and go back. That's great. Fantastic. Thank you.
Okay, so that was, oh, sorry.
Okay, so, okay, Karina, there you go. So that's great. And then walk back again.
So
so this is us just over 3 weeks after a right total hip replacement, having had the left 6 months ago. That's great.
So
thank you. Can you turn around? Can you just stand on one leg?
This lady's
stand on. Okay, so that's the side we just operated on. 3 weeks, and the other side. Absolutely brilliant.
So an emphasis in getting her anatomy back to where it's meant to be, and minimal muscle damage allowed her to return to really high level activities. I mean, she's running on a regular basis. She's in a rowing team. She's come to see Carl because she has tendinopathies, because she's basically pounding the streets probably too intensively. It's not her hip replacements that's holding her up, it's the tendons around it. So she's done really very well. What happens if we do this plan? So this is a young patient. So I've done my hip plan, and it demonstrates that my conventional implants just are not going to deliver. They're not going to deliver enough femoral offset to restore his anatomy. So if I use a conventional implant on this patient who's only 37 years old, I will not be able to restore his abductor length, and so he'll always be compromised. And this is a much more common scenario in the younger patient group. I do probably once every 2 months a patient that's under the age of 50, and probably I don't know, certainly every few months we're under the age of 40. The youngest patient I've done a hip replacement on, I think, is 16. So we are doing them in all age groups, but for younger patients, is very commonly because their anatomy is somewhat abnormal. That's why their hip has run into early degenerative changes, such as with this patient. He has this cam morphology to his femoral head, probably had a degree of a slip to his capital femoral epiphysis as a kid, but he's got similar anatomy to his other side. Again, that's not unusual to see. But that's why his hip has become arthritic at a younger age. So he ended up requiring a customized implant. And so you can see that's delivered restoration of his offset. When you see the lateral view, you can see, how curvy this implant is to fit his anatomy. So conventionally, we'd have to make a kind of a groove in his femur to accommodate a straight stem, which is quite often why some patients complain of maybe some thigh pain after they have a hip replacement. But the philosophy here is the implant is made to fit their anatomy rather than the other way around. And so his testimonial back to very, very high level activity. And I think the difference in trying to restore hip replacement patients are generally a happy group, but actually if you ask them in more detail about what their level of activity is, it's not uncommon to find that they start to describe some buttock pain or some discomfort as they're doing more exercise, and that's a sign of gluteal weakness, their abductors just not being strong enough, and commonly that's because their anatomy has not been restored at the time of hip replacement. And as we're doing this in a younger population and in a higher demand population, so our 60s and 70-year-olds now are looking to get back to skiing, they're looking to get back to playing tennis, it becomes all the more important that the focus should be on delivering and restoring their correct anatomy. So in summary, if we're accurately restoring the patient's anatomy, it improves their gait, it improves their speed of recovery, you're likely to have less in the way of complications, and certainly my experience is that the patients are extremely happy. So yeah, okay. So as Sir Tom can advocate. So I think that's me.